everyone, and welcome back to the ACL Injury Part 2. Today we are going to discuss more regarding the management plan and also the post-management plans. So you have probably been through my first video which covers the basics and how to diagnose an ACL injury. The next question comes is, how do you manage them? Well, as in any types of conditions, there are non-operative and operative modalities. For the non-operative, of course, this is only indicated in low-demand patient because you need to know that ACL is one of the knee stabilizers. It helps proprioception and it generally needs to be in good condition for the knee to function properly. And so non-operative is usually only indicated in low-demand patients. Now, the modality includes physical therapy and lifestyle modification. The next treatment plan would be to operate. Now, operation is usually indicated if the patient is still very young and it is a very active population, because repair of these ligaments will reduce the incidence of subsequent damage such as the meniscus damage. Operative is sometimes also indicated in older patients but who remain active, and it's also indicated in patients with prior ACL failure. Now, the operative techniques are various. You could do a ACL reconstruction or revision ACL reconstruction. For the basic ACL reconstruction, you need to identify first the associated injuries, because ACL injuries are frequently associated with other conditions such as MCL injury, meniscus tear, or PLC tear, and these structures also need to be addressed along with the ACL so that you can obtain a good function following surgery. Now, when talking about ACL reconstruction, there's always certain things that comes to mind when you're facing an exam probably. The techniques of the ACL reconstruction are frequently asked. The first thing that you need to know will be the tunnel placement. Since the ACL is gone, or let's say gone, because they are broken and no longer functioning, you need to replace them and place them inside a tunnel that is artificially made inside the femur and tibia. The next question that comes is, what sort of graft would you want to use in those tunnel? So trying to answer these questions, we'll start from the femoral tunnel. By knowing which specific location to place this graft in, you could reconstruct an ACL perfectly. From the sagittal type of plane, you need to place it around 1 to 2 millimeter. You need to leave around 1 to 2 millimeter rim of bone between your tunnel and the posterior femoral cortex, because failing to do so will cause blowout of the posterior femoral cortex and your graft will ultimately fail. From the coronal plane, you need to place it along the lateral wall, which is around 9 to 10 o'clock position, to achieve a more horizontal graft. The same thing goes for tibial tunnel placement. There are sagittal plane position that you need to know, which is that it should be placed around 10 to 11 millimeters in front of the PCL insertion, and it should also be around 75 degrees from the horizontal plane. Now, a lot of you may ask, what is going to be used to replace your ACL? Actually, let's go first from the placement. The graft should be fixated in the knee during surgery in around 20 to 30 degrees of flexion, because these are usually the position where the ACL reaches its maximum length. And then for the choice itself, the autograft could be used, or the allograft could also be an option, but generally people will choose autograft. For the autograft, there are several options available, such as the popular BPTB, also known as the bone patellar tendon bone autograft, or the quadruple hamstring autograft, or even the quadriceps tendon. There are actually other sorts of autograft that could be used, such as those harvested from the peroneals, but let's stick to the basics first. For the BPTB, we need to know that the advantages of using it is that it has a faster incorporation rate. You're actually taking a piece of the bone that is attached to the patellar tendon and you're fixating that bone inside the femoral and tibial tunnel. Bone-to-bone healing is indeed faster and it could lead to a maximum load of failure of around 3000 Newton, but there should be a little bit complication which includes anterior knee pain since you're cutting off a piece of the patella bone, and the complications may include patella fracture and patella tendon rupture. Now for the quadruple hamstring graft, usually you only need a smaller incision and it gives less anterior knee pain with a maximum load to failure of higher than the BPTB, which is around 4000 Newton, but the fixation strength is definitely weaker compared to the BPTB since the BPTB method provides bone-to-bone healing. Now the complication that may arise is the certain effect that may occur, which include the windshield wiper. Since you are actually suspending the ligament away from the tunnel, you are putting it in a suspense position that will cause the tunnel to be slightly larger due to erosion by the ligaments with a windshield type of movement. As you can notice, like in a car, the windshield goes from right to left, and that is how your ACL moves inside the knee during your knee motion, from forward to backward, and that will slowly erode the tunnel that is being made. Now, there could also be residual hamstring weakness because you have harvested it, and other harvest complications might occur during the procedure, such as saphenous nerve injury or weakness of the knee flexion and internal rotation. Now, the last choice of graft that could be used is the quadriceps tendon that is taken along with the patella bone plug, but is of course less common. Now, the allograft choices is there, but it is seldom used. It is only usually reserved in revision case. It takes longer for incorporation and it increases the risk of disease transmission because you're not using your own body's biological tissue. There's also the increased risk of re-rupture because it is generally weaker as compared to the autograft. Now, for the fixation method, you need to know that after you have created the tunnel and selected the proper graft to be used, you are going to fix the graft in place. And first of all, I need to explain to you about tunnel motion. This is what I'm talking about earlier, where the graft is suspended at a place that is a little bit higher than the original place where it will move. There will be certain effects that occur. If it moves according to this yellow arrow, it will create a windshield wiper effect. It goes from front to back, eroding the bones here and here. But it could also go in a in and out motion, such as the ones depicted in this blue arrow. It could go up and down, up and down. That is what we call a bungee effect. I will discuss about this a little bit later. Now, for the method of fixation, of these grafts are divided into two. Whether or not you're using a bone inside the graft, which is using the BPTB, or you are fixating a soft tissue such as the quadruple hamstring or the quadriceps or the peroneal tendons. Now, when you are fixing bone, there are definitely several types of things you could do. First, you could use a screw, whether or not it is absorbable or metal, such as these ones. These are absorbable screws, this one, and these are non-absorbable screws. And then you could also use a transverse compression technique in which this plug of bone is being compressed from a transverse directed force, also using a screw. And next, you could use a transverse suspension type of technique. In here, you could see here that the bone plug is being held in place by two pins that suspended this bone plug. And the last technique the other technique there that could be used is the hybrid system, where you actually suspend the graft using this pin here in the center, and you also compress the graft inside the tunnel through a transverse force. This is a hybrid system, and the last one would be press fit system. Now for the soft tissue system, there are another division based. It is different when it is used in the femur or in the tibia. For the femoral side, the graft could be held in place using a compression technique in which the soft tissue graft is screwed in place and compressed inside its tunnel. It could also be transfixed using pins that holds it in its place, or it could also be suspended. Now a lot of implants nowadays use this suspension system, or sometimes they call it these buttons. You put on buttons here and then you screw it here, and that is one of the most commonly used technique nowadays. You suspend it away from its original position, and there are also the hybrid technique. As for the tibial component, usually you can compress it in its place, same as the femur, or you could expand it. So you split away all the quadruple hamstring graft and you insert a screw right in the middle. And then there is also other options such as cortical anchoring, in which the suture is also fixated distal to the area of the graft using a cortical screw inserted at the anterior aspect of the tibia, distal to the exit point of the graft. And the last would be the hybrid fixation. Now, considering that you have learned about the graft, you need to know that there are certain points about this graft that you need to know, which is the healing phase. Well, the graft usually heal with a process called ligamentization. So it is changing the graft's properties from a tendon to a ligament. So during the first week, there is known as the inflammatory phase, which occur for around week 1 to week 4. And during this early phase, generally there is a central acellularity and necrosis. There's also an influx of host cell that carries inflammatory cell or fibroblast, and then followed by complete replacement of viable graft cells by host, usually in around 2 to 4 weeks, and no revascularization during this phase. Following that, during the week 4 till 12, there will be proliferative phase. And during this proliferative phase, usually there's already increased cellularity. There's also a revascularization of the tendon, and there will be increased glycosaminoglycans and increased collagen type 3. And there will also be increase in the smaller diameter collagen fibrils. Now, following that phase at the 12th week or the 3rd month, that is, following that is the ligamentization phase. During the ligamentization phase, we could see that the remodeling will occur, structural and mechanical adaptation will happen, there will be increase in the collagen content, and there will be non-reducible to reducible crossing ratio increase within the collagen fibers. And afterwards, you need to consider the last thing, which is pediatric population. They are very special population because they have an open growth plate, and the indications of doing this is only in complete ACL tear, and there are several techniques that may be done, including the intra-articular type, which may be physis sparing through the physis or partially through the physis, and it could also be a combined intra and extra articular type, or you could even do an adult type reconstruction, but only in male age more than 15 or female age more than 13. This is one of the image showing that the physical sparing combined extra and intra-articular ACL reconstruction is done using the autogenous iliotibial band. The iliotibial band is harvested proximally, and then it is left attached distally to the Gerdy's tubercle, and then the graft is brought through the knee with an in over the top position, and then the graft is brought through the notch, and then under the intermeniscal ligament anteriorly, and the final intra and extra-articular reconstruction after graft is sutured here to the lateral femoral condyle and the proximal tibia. Next would be talking about the complications. You can see that there will be some consequences when you're doing an ACL reconstruction on pediatric population, which include physical disturbance with the growth and physical injury to the growth plate itself. Now, you need to know that ACL tear in the skeletally immature patient may have a slightly different algorithm of treatment compared to the adult counterparts. These charts are good for reading, although they are not mandatory for you to remember the whole thing. You just need to take in what is the basic principles and keep that in mind. Next would be the talk about ACL revision. You know that sometimes ACL surgery will not go as smooth as you have predicted it, or it may go smooth as you have planned, but suddenly something happened and patient came back with cases of failed ACL and you need to do revision. So the certain points that you need to remember is that for the next reconstruction, you always need a high strength graft and use dual fixation and bone graft the tunnels if necessary to reduce the size of the tunnel diameter, and reharvesting of bone patellotendon bone is always contraindicated. Well, now that we have talked about all the operative techniques, we'll go to the post-management technique. So now, the rehabilitation is one of the most important aspects of ACL treatment because you need to do exercises that are correct. The exercises needs to be dominated by the hamstring. Remember, hamstring gives posterior force. Quadriceps gives anterior force. So you need to do exercises that avoid the hamstring activation. Now, if you are already ready to do the quadriceps activity based on your physician's evaluation, you need to do it with the knee flexed beyond 90 degrees to protect your graft. Also, any active knee range of motion should be between 35 to 90 degree of flexion. Remember that this is all during the early times. During the late phase of rehab, you could do all of this freely, but always under supervision. Now, the advice types of exercise is always the closed chain. So the closed chain type of exercises are the ones that you do with equipment and with your foot planted onto the equipment. You can try to Google and look out for more articles regarding the closed chain versus the open chain type of exercises. Now, during the rehab phase, the brace and crutch, they plays a very important role. Now, the brace usually needs to be locked in full extension during the first week, and it should be always unlocked for exercises during physical therapy. The brace itself can be discharged when the patient has full extension and no longer any lag with a straight leg raise test, and patient has at least achieved 100 degree of flexion. Now, crutches are usually used during the surgery for the first 4 weeks. The knee usually gets quite swollen up and the patient might feel discomfort walking without any crutches, but after 4 weeks, one should wean to one crutch and then discharge as long as the patient has a normal gait without any pain. Now, for the rehab, there are various rehab protocols out there. I'm just going to show you the ones I think is good to know. These are the phase 1 of the ACL reconstruction. You can see here that it is further subdivided into the intervention, goals, and rationale. The next phase is this one. The next phase is done from the first month until the 4th month, and usually during these times isokinetics in limited range is done, and there is walking program and also balance exercises. And the next phase would be the phase 3, where things are focused on the training of the neuromuscular system. So you need to do continued exercise from the phase 1 and 2, but here we already add some neuromuscular training and also plyometrics, which includes activities such as hopping and jumping. And during the end phase of the rehab, usually up to 6 to 9 months, usually the patient has normalized running patterns. The agility exercise may be started and the plyometric exercise too. And usually during this period of time, 6 to 9 months, the athletes or the young patients are prepared to return to their sport, always under supervision. Now, following rehab, you need to be aware of certain things or certain complications that may arise due to the treatment or due to the patient's own condition. The first would be aberrant tunnel placement. After the surgery, sometimes due to erroneous in surgical technique or anomaly in the patient's normal anatomy, the tunnel can be placed in an incorrect position, and usually if the graft is placed too vertically, there will be rotational stability. But if the graft is placed too anteriorly in the femoral tunnel, there will be limited flexion. This is a very good picture depicting most of the common complications of the ACL reconstruction. Starting from the first picture here, you can see that if the graft is placed too anteriorly, then there will be tightness in flexion. I only memorize usually one. If I see 2 points like this, I usually remember only one, because the other one should be the contrary. So I remember that any anteriorly placed structure will cause tightness in flexion. So naturally, anything that is placed too posteriorly will cause tightness in extension. Now, for the tibial tunnel position, if the tunnel is placed too anteriorly, like this one, there will be impingement during extension, and it will be tight in flexion. Remember, anterior flexion, anterior flexion. Okay, so if the tibial tunnel is placed too posteriorly, it will impinge with the PCL. Remember, posterior, then you will see the PCL. And then the next problem comes from the placement of the tunnel itself. If the tunnel is placed too vertically, then it will be rotationally unstable. So you want to achieve a screw divergence that is divergent enough to maintain both types of stability, which is the AP stability and rotational stability. Now, the last thing that may occur during the surgery is called the femoral tunnel blowout. Remember the femoral tunnel placement? It should be placed with only 1 to 2 millimeter anterior to the posterior cortical rim, and this can be achieved if the flexion of the knee during the drilling period is done with the knee flexed more than 70 degrees. If during the surgery somehow the knee is not flexed up to 70 degrees, you can see here the knee is slightly extended when the drill is being done, then the posterior femoral cortex will break, and this is called the femoral tunnel blowout. Okay, and the prognosis. People frequently ask, what happens after my ACL reconstruction? It is always mentioned that ACL has a risk of ACL tear has a risk of causing instability of the knee, but sometimes patient presents to us with ACL tear, but the knee looks fine even after the old age. So until now, there is actually no evidence that shows that ACL reconstruction reduces the risk of arthritis. But you need to know, instead, the chondral and meniscal injuries that occur at the time of the initial ACL rupture has been demonstrated to be the main predictors of arthritis change. So you need to know that during the ACL injury, other structures may be involved, and the involvement of these other structures have been the predictors of arthritic change. You can find various authors out there who write various papers and give various debates, and none of them are wrong. You just need to evaluate their work and read for yourself to determine how well they have done their research and if the data they present is plausible. I think that is all for today. Thank you for watching, and please subscribe to my channel Orthopedic Tutor for more videos. Thank you.